Good morning, everybody. It is 11:01 a.m. on the East Coast. I am Lisa Salberg, and this is Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. And I am thrilled and delighted to have our friend, Dr. Matthew Martinez from Atlantic Health's Marsden Medical Center's Shannon T. Mast HCM Center. Did I get all the names in there?
I think so. It's a mouthful.
There's a lot of names out there today. So good morning, Matt. How are you?
I'm doing well. Thanks for having me.
Always happy to have you here. And our topic of the month is one that is near and dear to your heart, pun completely intended. And that is exercise in HCM. We have a couple of announcements before we dive into this very complex topic. So I'll do my announcements while everybody populates so they can ask good questions during this podcast. Number one, it's June. So our topic of the month, as I mentioned, is exercise with a subtopic acknowledging grief and loss. I'll talk about that in a little bit. We have just dropped the agenda. It should be available by end of day for our annual meeting on October 27th in Boston, which will be co-located with the 8th International Summit on HCM, co-chaired by Marty Marin and Steve Aumann, also frequent guests here on Tales from the Heart. Matt and I will both be present in Boston, sharing our knowledge and learning from others. Go International Summit, along with a lot of other things we're going to be doing in the next few months, but that's coming up. So you can register as a patient to join us on Sunday. We will have some Saturday night activities, but that kind of brands with the summit. And it's a little fun to try to run two events in one, but we're going to do it thanks to great partnership. So that's what's going on in terms of messages. If you're in Portland, Oregon, and you would like to join us next weekend for a meet and greet, I will be in Portland for the ASC annual meeting. And we have a number of awesome HCMA representative patients who have agreed to help teach sonographers how to get Valsalva gradients by coming out and sharing their obstruction as a learning tool. So thank you so much to those who are volunteering. And if you're in Portland and would like to join us for dinner, you are more than welcome to sign up. Space is limited. Sign up by end of day today, please. Okay, so Matt, exercise in HCM. We've come a long way, baby. I was just having a conversation earlier this week with Stu Berger. I don't know if you know Stu. He's a pediatric cardiologist in Chicago, and he's the brain power behind the founding of Project Atom, which is a wonderful program that worked with for many years. So we were talking about where we were and where we are in exercise. And he brought up Hank Gathers, Reggie Lewis, because that's what we used to think. HCM, athletes, sudden death, destruction, don't do it, bad idea. And that's what we told everybody for a long time. And I think back then we were right because we didn't have emergency response systems. We didn't have good diagnostics. We didn't have great therapies. We didn't have a way to mitigate the risk of sudden death. It's 2024 now. Has the world changed a little bit in 30 years?
I'd say quite a bit. And I think a lot of things have changed. I think our understanding of the disease is different. I think our ability to risk stratify individuals is much better than before. We have more tools than we did 30 years ago by a lot. And we have a lot more data from Marty Marin on risk stratification. And that enhanced approach to using things like scar and wall thickness and family story are part of it. Apical aneurysms, LV dysfunction. And we're finding more. We're still lousy at it, but we're getting better at looking for individuals. There's no question, at least in my mind, that it's less about screening and more about planning and knowing what to do, hands-only CPR. We've taken away some of the anxiety related to the breadth of this. Is it 30 to 2? How many breaths do I do? Gosh, how deep does it have to go? Don't do that. Are they sick? Should we really be doing mouth-to-mouth anymore? So hands-only CPR, and then the availability of AEDs is not trivial, right? It is a huge difference. And in your community, to me, that's what your advocacy should be.
I couldn't agree more. I do have some late-breaking, not finalized news right now that I will share, and it is actually a result, in part, from our Hill visit in February. So earlier this week, or maybe it was late last week, a piece of legislation that I actually helped develop way back in the day, like 2010. It was called the Hearts Act. Frank Pallone from New Jersey drew it up. And it's just been this little piece of legislation that's kind of been hanging out for like 15 years, and it slowly evolved. When we went to the Hill, we had some conversations about the Hearts Act, which had made it through the subcommittee while we were there, which was really cool. But they've enhanced it and it's going to budget very soon, and it looks very promising. It will provide $25 million a year for 4 years to the CDC for emergency action preparedness in high schools, CPR AED training and planning, as well as cardiomyopathy education. And the language of the legislation says that the CDC must work closely with patient advocacy organizations in this space. So it's not done yet. It's going to need some more support to get through this committee and to the full House and then the Senate, but it looks incredibly promising, the most promising since 2010. So this might give us some more resources to do this important work. So yay.
Huge, right? And it's global money to act locally, which I think cannot be understated. The ability to get AEDs in front of people, to get folks to understand this. I was just watching a video of a cardiac arrest of an individual who was down a lot longer than I would have thought. People were watching, right? They were there. It's not like nobody was there, but there's a fear. I think they get stunned. I think somebody went down. I don't really know what to do. And what the SEALs have taught us is that you revert to your level of preparation. So if we can teach high school students and college students and lay folks, coaches, moms and dads, like we did in the state of New Jersey, as you know, and I can talk about that if we want to be more comfortable with it and to say when someone goes down, you check them, right? You start CPR. Are you okay? You okay? You initiate hands-only CPR. If they're awake, they'll tell you. They'll tell you to stop. That's okay. So there are opportunities to create an emergency action plan that includes fast action, hands-only CPR. You have been involved in this space for 15 years. I see Ross is putting in the chat that the drill Dr. Hart that has been part of what you've done for years. We recently updated that on the website, but there's an opportunity to improve the outcomes because there's a lot of action around ECG screening. There's a lot of discussion about should we be diagnosing. And the reality is that if you look at the high profile cardiac arrests in the last 2 or 3 years, what we know about them for sure is that they survived because of an emergency action plan and an AED, and all of them have been screened. So it's important to recognize where you're going to put those resources. And as you say, those resources are part of education for safety. And that player health and safety comes from EAPs, AEDs, preparation, no doubt.
And I think the easiest way, and I do repeat myself sometimes on this podcast because I want to drill some thoughts home to people. Hank Gathers, Reggie Lewis, late 80s, 1990, DeMar, Hamlin, 2023. And the difference in those responses, we do not expect community sports teams to have NFL level response teams, but they can do better and they can learn. And we really want to get that out there. So stay tuned for some programming updates and some more opportunities for you to get involved in your community to teach these basic concepts and help people stop, think, prepare, then act.
Absolutely.
You don't want to act and then try to prepare. You want to stop, think, plan, respond. That's what we want you to do. So awesome stuff to do on that space. So that's the bad side. That's the old concern. Well, not the old concerns, but those are the concerns about why we benched people with HCM. So now through better understanding of the disease, better imaging, better risk stratification, better planning, hydration, electrolytes, emergency action plan ahead of the participation. It is now the day of an NBA player, an NFL player with active diagnosis, managed shared decision making with all the key stakeholders participating. So how did we get here?
I think we got here through all the things you just said, and we got here through being critical of our own understanding of a disease that, despite 50 years of activity and incredible movement forward, we're still learning about. There's still more to come, and I think we got here through a discussion that you just said, which is that we better image, we can better understand risk, and then what we know is that exercise is important for virtually every other condition in medicine. We know that exercise is medicine. It's our best blood pressure drug. It's our best lipid drug. It's our best weight management drug, mental health drug. And it is improving outcomes in those with cancer, in those with other diseases, and with HCM. But it doesn't mean that we're now saying, have at it, start running marathons, don't prepare, don't worry about those HCM doctors. That's not what's being said.
Not at all. Quite the opposite.
Quite the opposite. What we're saying is mild to moderate exercise, it's important. In fact, it's the best way to prevent yourself from having those other complications that HCM patients have later in life, because coronary disease, hypertension, obesity, elevated cholesterol, those are bad combinations with HCM. And we want to avoid that as you get older. And the best way to do that is to prepare for it in your 20s and 30s with what you consume, maintaining a healthy body weight, and then exercising. So mild to moderate exercise virtually for all, but they still need to see an HCM doctor. You need to determine what your risk is, and you need to be evaluated and have what we call an exercise prescription, right? That someone is giving you information about your own risk, about what they think is safe for you, and you already touched on it. What about hydration? How far can I go? Should I have a partner with me? What types of exercise should I be doing? What's a safe way to exercise? So that's for everybody. And that's mild to moderate exercise. There's a beautiful figure, central illustration in the guidelines that goes over this, encouraging exercise for HCM patients. And it's got a green, yellow, red. Green is, up to 3 METs, which is mild to really mild exercise where you can still have a conversation. It's a brisk walk. It's aggressive housework. It's yard work, walking with your significant other. It's what we would say is a 20 to 30 minutes of activity where your heart rate gets at least to 110 beats a minute for most people. That's green.
What's yellow?
So yellow is like 3 to 6 METs, which is a little bit different. So that's more like vigorous exercise. And we actually wrote this exercise prescription, as you know, in the learnhcm.org. We wrote these separations. That means that you have trouble having a conversation. If you're walking with somebody, you're using short, quick, can't get out a full sentence, can't sing when you exercise. So green, you can sing, you can move along, you can have a conversation. Yellow, can't sing, still having trouble having a conversation, but you're still able to get words out, right? If I asked you how you were doing, you can impact. And then that you want to do again, 20 to 30 minutes. I always tell people the goal is 100 minutes a week. You can break it up any way you like. The AHA tells us 150 minutes, right? But I like 100. It's a little bit easier for folks to remember. And the 100 ends up being, how about 2 50-minute walks on Saturday and Sunday? What about 5 20-minute walks in the morning during the work week and taking the weekend off? That gets you to that 100 minutes. And that should be a combination between mild to moderate and vigorous activity in that yellow group. And then the competitive athletes, well, that's a different story altogether, right? That's 6 METs or beyond. That's high level exercise. That's the Jared Butlers of the world. Now that requires a different level of expertise and isn't probably for every single person with HCM, but it requires a level of risk stratification and assessment. And then all of them require the ongoing surveillance of those with HCM. So that's really critical. It's not a once and done. You still need your HCM experts. You still need your ongoing assessment. And it's not off you go. Thanks for coming. You've got HCM. It's quite the opposite.
I'm not going to use names, but I do hope to have him on here soon to discuss this. I have a client, you have a patient in common, who recently, he's an exercise hound, and he comes from a really scary family history. And he's had an ICD for many, 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 many years. And he called me 2 weeks ago and he's like, I had a bad day at the gym. And a bad day at the gym for somebody with HCM and an ICD is always something you want to say. And exactly how do you define that? And not only did he have a cardiac arrest while exercising, which he does all the time. He's a treadmill guy. He's on the treadmill, felt a little dizzy. He went, He goes down. Somebody comes to his aid. He gets up. He walks home. He goes home because he was well risk stratified and he's protected. Right. Of course, then I said, This was in a public gym. He said, yeah. I said, was there a video? And he said, yes. I said, go get the video. He got the video. Scariest video at one point and most amazing at the other, right? So here is all of, 50, 60 years of work understanding HCM in the most amazing survival moment. And he got on with his day. And he's said, I think I'm going to tone down my exercise until I figure out what's going on because my heart is a bit pro-rhythmic right now. I'm like, good idea. And he's checking in with everybody and he's kind of in chill out mode right now while his heart recovers from this event. But he'll probably go back to exercising once he gets his arrhythmias managed.
Yeah.
And he finds so much benefit to exercise. So it's not a yes or no. It's a shade of gray, and your shades can change day to day, season of your life to season of your life. And you have to stay in touch with your expert to identify what's the right level of exercise for you today and in the next period of time, and reassess that regularly. I came up in a time very different. And I don't know how to run. I don't know how to run because I never could run. I started having symptoms when I was like 11.
Wow.
So I never learned how to run. And then when I was diagnosed, I was told exercise could kill me. So I was afraid to run.
Yeah.
And then as you're getting older, you're like, no, you have to go to a gym. I'm like, I'm afraid of a gym. And then I had to learn not to be afraid of a gym. And then I had to learn how to exercise. And now my joints are crappy, so I'll never learn how to run properly. So that's just never going to happen for me. But I do get out and I kayak and I hike and I do the things I'm comfortable in doing with my transplanted heart. But I was also doing most of this with my HCM heart.
Right.
But it took a lot of time to be comfortable with exercise after coming up from the 80s in this world of HCM that it was dangerous. And I think we've got a nice balancing act now. Is it going to get easier? Is it going to get better? Are we going to be more precise for people? Do you think it's?
I hope so. I still think there's more to understand. Some of this is just chance, right? This is a challenge, right? Where I have a young athlete who has been very vocal about this recently, who had lots of exercise. We've done shared decision making with him. He did not have a defibrillator. It's done very, very well. And then while just walking slowly on his treadmill, he had an event. So it's just chance. Now he's done terrific. He's done well after that. He's now has his ICD. Of course, he qualifies after cardiac arrest. I think it's just a reminder that it's challenging to still predict this, but there's still more growth in this space. I think there's still more information we may be able to glean from MRI. I think we need better longitudinal data. I think we need larger databases to really follow folks and try and look for signals. And as you know, all it's trying to be worked out because it's really important. I mean, there's so much seminal work that Barry Marin did and others, and we need to now take that to the next level with newer tools we have with a smaller world population and really try and do a little more collaboration amongst all the sites.
That is, I'm going to leave this out there for the listeners as a teaser. I'm working on something I think could be amazingly great for all of us. Academic, community docs, patients in other countries, potentially even. I've got my eyes on something that I think is going to potentially be a game changer for communication and understanding. And that will then give us the platform to get more data for the critical analysis of the next level of decision making and the identification of gaps. So, wow, did I sound really nonprofity there?
It's important.
I am. Yeah. So we're getting there. So today, 2024, June, it's also AED CPR Awareness Week. So let's take a moment to just acknowledge that and to push the idea that the HCMA still has 4 AEDs to give away in our Drill Dr. Heart Challenge because we haven't had enough people apply. You can apply. We've made the application process a little bit easier. You can go on the link that Roz is dropping right now. And if you're listening in Podbean afterwards, look at 4hcm.org and look at our Drill Dr. Heart challenges. While this is June of 24 and the challenge is open right now, we may have other challenges in the future. So you never know, go check. So we want to help communities plan for cardiac arrest. And we also want to make sure that they have the resources such as AEDs or access to AEDs that they need. So we talked about our AED. We talked about exercise. We talked about where we're going next. But if you're a patient diagnosed today, What should you be asking your doctor about exercise for the newly diagnosed?
Yeah, so you're just about to bring up the same discussion. So if you're a patient, you should be talking to your doctor about what you do. What do you do? What do you like to do? What types of exercise do you do? And then she or he can help you figure out how to do it better, maybe how to better prepare for it, and then remind you of all the things that you probably have heard before. In the office where we see patients, there are posters on the board, on the walls now, to make sure that people look at it and start to say, can I do that? Am I allowed to do that? And then it forces me in a busy practice, right? We all get busy, and I have a lot of time to see patients, but you still get busy. It's really no longer a should we have this conversation. It's kind of like this is state-of-the-art care for HCM patients. Like we should be risk stratifying them. We should be talking to them about pregnancy. We should be talking to them about atrial fib risk. We should be talking to them about symptoms. And yep, we should be talking to them about hydration and what their exercise level is. So if you're a patient, you should be asking your doctor about how much exercise you should do and how safely you can do it. Is there anything else you need to do to prepare for it? And then talk to he or she about what a plan might look like. Because what I just described to you, mild to moderate, that's still complicated for folks. And this is a chance for them to better understand what level you are and what's a bare minimum. So if you're a patient and your doctor is not talking about it, we should be. And if we don't bring it up, you should. Just like having your own AED, just like making sure that you're exercising in a safe environment, take a little bit of personal responsibility and bring this up with the doc. You mentioned it already. Was this in a public space? We talk about that. Are you exercising with a partner? Are you exercising at home? Terrific. Is someone home when you do it? Are they CPR trained? Do you have a home AED? Where do you live? Do you live really rural? Do you live across the street from Morristown Medical Center? So all of that goes into this discussion. It's really an easy conversation to have. It's rarely a once and done. It's usually sort of an ongoing process. I have one patient who comes back every 3 or 4 months because she's really scared. And she comes back because I need to encourage her to exercise. I don't think she would be upset about me talking about it. She's scared and said, I went so long, almost verbatim with what you just said. I went so long with non-exercising that this idea that I should be exercising now is really scary. And we kind of nudge her along and little by little, she's getting a little safer. We did a stress test so she knew what she could do safely and what she was comfortable, like sort of what those levels might look like. And there are some ways to create an exercise prescription that is unique to you. And we owe it to you as your provider, for sure.
I have a tendency to keep looking forward, and we're going to keep changing the future for the better. I have an injury right now. I have a plantar fasciitis issue in my left foot.
Ouch.
Completely unrelated to anything. But as I was trying to figure out why my mobility is not where I wanted to be at my age, and I'm talking to a physical therapist about my life of exercise and how I've gotten to this point, I had this realization like, wow, I'm a hot mess. So I had a stroke when I was 21 years old. So my left side is a little weaker than my right side. And as it turns out, some of the small muscles in my foot may have actually been affected neurologically from my stroke. And now as I'm aging, I'm starting to see these other problems. So we talked about exercise and what I've been doing and how I've been doing it and when I started doing it. And I didn't start really exercising until about 2004. And when I look back, I'm really glad that I did start to do some exercise in 2004. And I was a gym rat for a number of years and I got conditioned, but then my heart started to fail. And then I got more sedentary and then I transplanted and then I kind of gave up the gym because of germs and then COVID. So I thought about that timeline and I think that change of becoming more active in the early 2000s actually helped my recovery from my transplant because I had some muscle tone to lean on. I had some knowledge of how to move my body and how to condition it. But between the transplant and COVID and aging, I've become stiffer and I'll hike and I'll kayak, but I'm not going to the gym. And I think I need to bring that back into my life.
Yeah.
But there's these messages from my past about be careful. And I've seen too many videos.
Yeah. Well, and that conversation then, as you know, hits you like a ton of bricks when all of a sudden you realize your heart may be failing. I'm 50 something years old and I'm out of shape and I'm exercising, but I'm not exercising. Am I a transplant candidate still? And that's the conversation I now have with people earlier on when I sort of see them going in this direction. It's very unsatisfying for both of us, where I say, you got to lose a lot of weight. You've got to get in a lot better shape because you're probably going to need a new heart, and there's no chance you qualify where you are right now. And it's really important.
I'm going to bring up another topic because I'm dealing with two of these individuals right now. And I'd like you to take a moment while we're talking about exercise and fitness and weight to talk about smoking.
Oh, gosh. I mean, the short answer for smoking is that it's an absolute no. It's a no-go. The only thing that should go into your lungs is air. I'm not a vape fan. I'm not, any of these, anything that goes into your lungs at all. So your lung tissue actually deteriorates with time, whether you like it or not. They're big bags of they're big bag filters, right? So about 1% of your lung function goes down with regular everyday life, whether you're an HCM patient or not. All of us lose that. And if you smoke, you just make it more aggressive. So you're deteriorating your lung function. Makes it also difficult for us to figure out, are you breathless because of your heart? Are you breathless because of your lungs? Which treatment am I going to deliver? And then, of course, we know, this is not news, smoking and coronary artery disease are intimately linked. So we are just putting yourselves in a bad position. So this is old data from Mayo. Paul Saraja showed this years ago that coronary artery disease, the more vessels you have, plus HCM, the worse the outcome. So this is a sinister combination. So the short answer is you can't smoke, period. And we have to do everything we can to eliminate it.
You brought up coronary artery disease, and yes, our topic is exercise, but I do want to ask you another question. We didn't prepare for this, and if you don't have an answer, we can get back to them later. Lipoprotein A.
Yeah.
I'm on Repatha because my lipoprotein A was through the roof. It was crazy. And they're like, you need action right away. I'm like, I had no idea. Can you tell us what lipoprotein A is and why we might want to know about it?
Yeah, so lipoprotein A and ApoB are the two sort of novel additional cholesterol markers, and they are both associated with a more aggressive form of coronary artery disease, often a younger form. And it is in addition to LDL. It's part of the cholesterol workup. They are additive to regular cholesterol evaluations. However, we know that the higher the number, the more aggressive your risk is, the higher your risk for coronary calcification if the Lp(a) goes higher, like over 100, 150, over 200.
400.
Oh boy, super high. And it's an inflammatory response. And it is definitely a marker for bad outcomes with regards to coronary disease. Here's what we don't know, and this is the challenge. Right now, what we would say is if you have it, aggressively treat your LDL, get that cholesterol, total cholesterol and your LDL as low as we can. We don't know that lowering the Lpa will have any benefit to outcomes. And that's all being studied right now. So over the next few years, we're going to figure that out. I love that you're doing an injectable PCSK9 because this is important. It's probably our best way to lower the cholesterol. You can virtually halt coronary disease progression by dropping an LDL to 55 or below. And you can do that for a whole bunch of ways. The easiest way to do this is with PCSK9, but usually you have to go through one of the statins to get there. Usually high doses of statins, you have to be intolerant to it, or you have a high calcium score, or you have familial hypercholesterolemia. And we do all those tests. So LPA and ApoB are add-ons. They're not always covered by insurance. It's probably worth you knowing this if you're somebody who's asking, should I do this or not? And my LDL is 250 and my dad died when he was 55 from a heart attack. There's real value in knowing that and then getting aggressive about treating it. We'll find out in a few years about the what therapies are best. But in the meantime, there's no reason not to.
Yeah. So my dad, who today is the anniversary of his passing, he died on 6/7/08. So it's an easy day to remember, unfortunately, or fortunately. But dad had coronary artery disease on top of HCM.
Yeah.
So I have that risk from his side. And my mom definitely, my mother was doctor averse, very strange, but she had coronary artery disease as well and died of heart failure. So I had the double whammy. So after transplant, I'm like, okay, let's get this checked. So I now know, and I'm more at risk of CAV than CAD. So the test was really enlightening for me. And I did it at ESC in Amsterdam at one of those little booths in the convention center. I'm like, oh, I'll just do this test. And I went to pick up my results and they just kind of looked at me and they're like, we've only seen a couple this high. Please talk to your doctor. So I'm like texting it back to my transplant team from Amsterdam. I'm like, I think we need to act on this. And my numbers went down to like 52. So I went from like 70 to 52. So yay,
Yeah. And so this is, this goes back to what we were talking about earlier, right, where the diagnosis really helps, right? It turns out that if you don't know what to treat, it's hard to know how to treat it. And this is an opportunity. Again, as HCM care evolves, the discussions with a 20-year-old, a 14-year-old, a 30-year-old about life and their risk and complications are different than they are when you become 55 or 60. All of that changes.
We change over time. We definitely change over time. We've talked about exercise in the current day. We've talked about the past day. We've talked about some potentials for the future, but we don't have enough data yet. What do you think we need to know next? Where are the gaps as you see them in terms of getting more precise with exercise prescriptions?
I just think we need more information. I think we need more data on safety. I think we need to know more about how much folks can exercise. I think this is really important.
We're going to keep the work going.
I'm sorry to do this to you. I just got called for an emergency.
I saw the look on your face. I'm like, I think we're going to wrap up now.
I apologize. I have to go.
You have to go. That's the life of being a doctor on a weekday. Thank you, Matt Martinez, for joining us today. I'm going to stay and talk to our guests for a little bit longer. And I thank you for your time and good luck to your patient. That's the second time that has happened on Tales from the Heart, a podcast. So sorry about that, but I think we got the great information out of him today. I will take the last few minutes of podcasting today and bring up the secondary topic and an acknowledgement here of the second tone, and that is grief and loss and talking about it. For those of you who've known me for a while and those of you who don't know me, let me tell you that I'm not a fan of the month of June. It's a beautiful month, graduations and memories and all that kind of fun stuff. My sister's wedding was in June. Happy anniversary, Lynn and Kevin. But the rest of June has been pretty rough for our family. Today is the anniversary of my dad's passing. My dad was not diagnosed with HCM until later in life because of everybody else getting diagnosed. He had been mismanaged for many, many years, being told he had anxiety and maybe a little exercise-induced asthma and hypertension. It wasn't until he was 59 that he was diagnosed. By the age of about 69, 70, his mitral valve had completely deteriorated. His right and left atriums were so dilated. They, in fact, are still, I believe, the largest left atrium and right atrium operated on at the Cleveland Clinic in 2006. My dad went through a lot, and at the end, his kidneys failed. My dad was brave. I want to tell you how my dad died, because I think talking about death is something we don't do very well. And I think it's okay to talk about death. So when my dad had his open heart surgery, it was really, that went well. He had a really complicated path of recovery. He spent 31 days in intensive care. And thanks to the wonderful team over at Cleveland Clinic, they got my dad through it, but his kidneys took a big hit. And he went into advanced kidney failure. He had been on dialysis short-term in the hospital, went home, things were better. And that was in July, August of 2006. And then in December, he had an acute episode of kidney failure, landing him in the hospital 2 weeks before Christmas. My dad loved Christmas. He was the present guy. He was the Santa Claus. He literally was Santa Claus. My dad was Santa Claus. So it's 2 weeks before Christmas, and he's afraid of dialysis because genetically we have terrible veins and terrible access. So the access point to my dad was just really traumatic, as it is for me and many other members of my family. We have terrible veins. So dad didn't want to do dialysis, and it's 2 weeks before Christmas. And I said, do you want to be here for Christmas? And he said, yes. I said, then I'm going to make you a promise. If you do dialysis and you start it, whenever you want to stop, I promise I'll have your back. be careful what you promise people, because sometimes it's really hard to follow through on those promises. But you do it because you promised. So that was December of 2006. In February of 2007, we went to the Florida Keys, and he was able to go, and we got him on a boat, and we went on a charter, and we caught a 45-pound grouper and a lot of mackerel, and we made a lot of smoked fish and a lot of great memories. He went back to Florida the next year, and the dialysis caused his defibrillator to go into a storm, and he survived it. He came home, and that was his last trip to Florida. And when he came home, he had a couple of good months. And then it was the weekend of the HCMA's annual meeting. And the phone rings at about, I think it was Thursday night. Friday afternoon, the meeting actually started. And my dad said, I need to talk to you. And there was a tone, and I knew what he wanted to talk about. And I knew he was tired. And he said, I'm done. And I said, those are really hard words. I'm done. But he made the call. And I said, Dad, I know I promised you I would have your back, and I do. But could we do this on Monday? Because I have 300 people flying in from around the country, including 17 faculty members. And I have to focus on a meeting this weekend. Could we do this Monday afternoon, Tuesday? Could we have this conversation? Monday was our golf outing. So it was weekend of like intense work. And this is when Dad says, I've had enough. So I went and I had the meeting, and I put on a face, tried to hide my grief, but everybody knew, and they were really sensitive and awesome. And I thanked them all for their compassion. Monday, we had the golf outing. While we were on the golf outing, I don't golf, so everybody else is out golfing, and I'm planning the hospice bed to be moved to my house. And it was just logistically, my parents lived around the corner. So Monday night after the golf outing, his volunteer fire squad, Hibernia, Company 1, Rockaway Township, shout out. His team came to his house to bring his ambulance. My dad designed the ambulance. My dad served on the ambulance for many, many years. They brought his ambulance to him, and they moved him from his house to my house. And as my dad went down the sidewalk, it was lined with all of his department friends and colleagues, and they shook his hand and they high-fived him. And if you have ever seen the movie Big Fish with Albert Finney, the final scene where he's going into the water to swim away to be what he always was, a big fish, that's my father. That's my father's personality. That's my father's death. I cannot watch that movie without breaking out in tears at the end, but that's my dad. And he did that. He shook everybody's hand and he said goodbye, came to my house and spent five days there. And on the sixth day, the eighth day without dialysis, he passed away, which was today. And my dad had a beautiful death. He went with the people he loved around him. He said thank you and goodbye and keep going to everybody who meant anything to him. Friends came to visit, relatives came to visit. My dad had a beautiful death. And I wish that for anybody else, that you can do that for the people that you love the most, is give them a beautiful death. So I was able to do that for my dad. June also has a lot of other scars for me, and I'm not going to use this as therapy, but I will tell you that June 12th was the day that my sister had her cardiac arrest. June 16th is the day that she was declared dead and became an organ donor, which was the 5th anniversary of my stroke and diagnosis of endocarditis. And I don't like June 16th, but this year I will be in Portland, Oregon with lots of great HCM folks spreading awareness for this particular day. And lastly, but not least importantly, on June 21st, 1953, was the day that my grandfather had a cardiac arrest at the age of 42. And my father tried to do CPR on him in 53. My father did CPR on his daughter in 95. And my father was successful on my sister and unsuccessful on his father. There's a lot to process in all of these stories. And maybe, just maybe, that gives you a slight bit of insight as to why I am so passionate about finding those with HCM about making sure people get proper care and making sure family screenings happen and doing the things that we're doing to change the future for those with hypertrophic cardiomyopathy. The future does not have to be like the past. And it won't be like the past in my family because my generation and the next generation and the next generation have better access to care. So if you've ever wondered my why and why I'm so passionate and what I've been through, that gives you a little glimpse. So to those of you who are processing loss and living in grief, generational grief in some cases, please think about it. Please process it. Please come to an HCMA discussion group and share your feelings, get it out. No, you're not alone. I know I'm not alone. And I know many of you have worse stories than my family and different stories than my family. Grief and loss can bring out some really, really deep emotions and feelings. I will try to get back to writing my book this summer, and I promise you I've been teasing this book for a long time. But life with HCM isn't just the cardiac disease itself. There are other things involved here. And after a loss, there are real life issues that come into focus, and you might not have had to deal with them before. Custody of children, finances, Social Security benefits, who gets them, how do you raise families when there's a missing person, how do you heal, how do you financially, emotionally, and physically get past and through and live in, and all of those things matter. You have to live in the moment, you have to process the moment, and you have to move on from the moment. But moving on doesn't mean we ever forget. So to those of you who've lost somebody, I know. I don't know exact, but I know enough. And it doesn't have to be a loss from HCM. We all deal with loss. It's part of life. But to try to time death and do it on your own terms, this, my dear friends, is my goal. I'm going for like 83. I don't know why I feel like 83 is a good year or lifespan for me, but I'm going to try to make it to there. And in the meantime, I'm going to be here with you guys trying to do great work to save lives and improve lives and find the undiagnosed and build programs and change the world for the better. So get out there and exercise. It's a beautiful day here in New Jersey. It's sunny. It's gorgeous. There's dragonflies everywhere. And dragonflies are kind of my dad's sign. On the day of his funeral, which of course was on a big fire truck, Mom wanted to be cremated as soon as possible. No big thing. My dad wanted fire trucks and banners and honor guard. My dad wanted it all. So he got what he wanted and Mom got what she wanted. Do death your own way. But we did last call at the firehouse. And if there's any firehouse families out there, you know what a last call is. So the fire truck with his casket on it comes in front of the firehouse and they do last call. And they put his boots and his hat out and they ring the bell for him and they open the doors and they close the doors and they take him to the cemetery. That's last call. And during last call for my dad back in 2008, there was a dragonfly hatch. I am not kidding you. There wasn't like a couple of dragonflies around. There were hundreds of them all around us. So dragonflies are my dad. And I'm looking out the window right now and there goes another dragonfly. It's dragonfly season in Jersey. I love it. So I feel my dad's presence and I hope you do too. While his name was Lawrence, everybody called him Larry and he was a character and I miss him every day. So to all the character dads out there, happy Father's Day later this month. And if your dad is the one with HCM or lost to HCM or involved in the HCM community at all, sending lots of extra love out to them today. So to all the dads, thinking of you. All right, ladies and gentlemen, that wraps up this episode of Tales from the Heart, a podcast from the HCMA, and we look forward to speaking to you soon. Please remember to call for your intake and navigation calls and sign up for our events online. And thank you to our sponsors.
The Hypertrophic Cardiomyopathy Association thanks the following sponsors for today's podcast: Cyokinetics, Bristol Myers Squibb, BioMarin, Tenaya Therapeutics, and Viz AI.